Good afternoon, everybody, and welcome to 13 Now. I am News 13's Amy Hoyt. We're coming to you live from our newsroom in downtown Panama City. It's good to have you with us this afternoon. As you know, once a month, we remind you our Buddy Check reminder to check for lumps in your breast to make sure that you don't see some changes. And if you do, to, of course, check with your doctor. One of the biggest parts of treatment for breast cancer when you're diagnosed, most women, I would have to say, but we'll ask the doctor in a moment, go through some form of surgery. And we do have a new breast cancer oncologist with us here in Bay County today. I'd like to introduce her to you now. Her name is Dr. Alison Moody, breast cancer oncology surgeon from Ascension Sacred Heart Bay. Good to have you with us.
Thank you for having me. It's good to be here.
Tell us a little bit about yourself first, since you're new to Bay County.
Good. Well, I've lived all over the country growing up, did my medical school and got a master's degree in public health at the University of Miami, and then kind of started moving west, went to LSU in New Orleans, where I did general surgery residency. Met my better half, Dr. Chris Johnson, who's also a physician here with Ascension, surgeon actually. And then I went out to Los Angeles at Cedars-Sinai for a year to really focus and specialize on breast with some experts there. And then Chris and I packed up our 6-month-old, our dog, and drove all the way back across the country where we've made Panama City our home.
Well, we're happy to have you here, and we appreciate, of course, having a new surgeon. It's such an important role that you play. Tell us a little bit how breast cancer has changed. I mean, there's so many, when we interview survivors, there's so many different kinds of breast cancer. It's kind of mind-boggling.
It's breast cancer. One of the amazing things about the field is it evolves rapidly. Tons of research money has gone into this field, and with that, the advances are really impressive. Just, in the last few years, we've seen huge trials which have really changed the landscape of chemotherapy that we offer for breast cancer, with really astounding results with regards to survival and patient outcomes. Surgically, we have, proven that we can de-escalate a lot so that we're no longer doing really aggressive deforming surgeries, and we're, continuing to get great outcomes with that. I could go into a lot of details, but the field changes rapidly, and that's a lot of credit to the research that's continued to kind of propel that forward.
What kind of surgeries are there? I know that they're different obviously from patient to patient. Sometimes it's just a lumpectomy, and then sometimes it's radical, where you remove both breasts. So what do you see, and what's the difference?
So every patient who sees me usually sees me with a consultation of an initial breast cancer. Kind of the first big decision is, do we move to surgery immediately, or is that a patient who's better served by upfront chemotherapy? The factors of the biology of their cancer, tumor markers on their cancer, the size of the disease, whether or not it looks like they have lymph nodes involved, will kind of lead us to that branching point of saying, you're a patient who's better to do surgery up front, or you're a patient who will have better outcomes with chemotherapy up front. In patients who do surgery up front, a lot of them will be patients who have had screen-detected cancers, smaller cancers with minimal or sometimes no node involvement. And when possible, it's great to be able to do a lumpectomy for these patients. We know that regardless of surgery, whether we're doing a mastectomy where the entire breast is removed, or doing a lumpectomy where you're simply removing the cancer with a negative margin, that survival rates is actually the same as long as we do our job and completely clear the cancer from the breast. With lumpectomy, patients also need to get radiation. So we know that good survival outcome comes with a combination of treatment with both surgery combined with radiation. Mastectomy is a little bit more complicated. I could give an hour talk on that, of who needs radiation and who doesn't. It is still sometimes indicated to ensure good cancer outcomes, but not all the time. Really, that decision comes down to looking at the details of that patient's final pathology. In most patients, not all patients, we also do a something called a sentinel lymph node biopsy. If we think a patient does not have a node-positive disease, the disease is still confined to the breast and hasn't started the process of spreading to the lymph nodes, we do a procedure where you sample the lymph nodes to ensure that is the case. We know that even when we look with ultrasound and when an experienced provider does a clinical exam, that about 10% of the time we're wrong. And we don't want to assume that, so we sample the lymph nodes. The This procedure was actually invented by the person I trained under out in Cedars-Sinai a lot of years ago, a really special man and surgeon, Dr. Armando Giuliano. And it's really helped us to de-escalate the complication rate for surgery, because rather than removing all the lymph nodes to make sure we've cleared the disease, we map out the first draining lymph nodes. So in this procedure, usually either
During the mastectomy?
it's done during the breast surgery, either a lumpectomy or mastectomy. Either the night before surgery or the morning of, a patient will get injected with a nuclear medicine tracer. People hear that and usually get concerned. They hear a nuclear medicine tracer. It's actually so safe that we give it to pregnant patients without any harmful outcomes to the fetus. So it is a nuclear medicine tracer, but incredibly safe. And then the day of surgery, before officially starting the operation, I inject a blue dye into the breast in the operating room, and I actually give all of my patients a 10-minute massage where I pump that blue dye through the breast into the axilla.
It sounds like a PET scan.
Fortunately,
Right, the blue dye.
well, fortunately for us, the breast has a reliable draining pattern. So the breast will drain to a few first nodes, and then it drains to the remainder of the axilla. And then from there, it can spread to the rest of the body. Occasionally, it can drain to other nodal places, but the normal transit of breast cancer is from the breast to those axillary nodes. So with this procedure, we're able to figure out how these tracers move and are picked up first and in highest concentrations in the first nodes draining the breast. So rather than removing all the lymph nodes from the axilla, which is usually 10 to 20, you'll selectively remove a patient's what we call their sentinel nodes, their first draining nodes, which, I always tell my patients, you have the number you have. Some people have 1, some people have 3. I think I took care of somebody once that had 5, which was a little strange. But whatever are your first draining node or nodes, we remove. And then they go to the pathologist and they analyze them by taking small little sections, looking under the microscope, doing stains, making sure there's no evidence of cancer cells within those nodes. And in patients who we identify that there is no cancer in those nodes, we're fairly confident that there's no cancer in any other nodes either. So we can save more aggressive surgery with removal of lymph nodes and the possible complications of that, like lymphedema.
You said that you trained under that doctor at Cedars-Sinai. Cedars-Sinai has a wonderful reputation both in LA and New York, right? There's one in New York City.
The Cedars-Sinai, the one I trained in, I guess they are a little bit related, but it kind of function as 2 independent campuses.
Oh, they do.
So
okay. But they both have great reputations.
Yes,
Yeah.
they do.
What made you choose this field? Because you're also a general surgeon.
I am. So I'm still a general surgeon. I think that's an important thing to say that, I did, same as everyone else, I did 5 years of general surgery training, trained in every procedure to operate from thorax to the abdomen, and had a great surgery experience at LSU. Really loved that. Doing a fellowship in something is kind of icing on the cake. It adds to that. I liked the concept of being able to have a skill set and to offer something at, a higher level than somebody who's trained broadly in all procedures, to really narrow in and focus on an area and to be able to kind of bring that added expertise. I think a year of fellowship for me and a year of really focused training under leaders in the field, both learning from them about surgical skill, but also a huge part of it just learning about decision making and how to direct patients through the cancer journey, and learning about the other treatments for cancer, learning about chemotherapy and radiation and when they're indicated and how best to line treatments for outcome was incredibly valuable. I love breast. I like cancer care. I think there's something really special about kind of getting to follow cancer patients on their journey from the diagnosis to the cure. And then an amazing thing about cancer care is once patients are cured, you continue to follow them. So you have a lot of really exciting visits where they're coming back to your clinic. You're doing imaging, you're doing exams. Breast cancer, our outcomes are excellent when we get people through their treatment. So most of those are really happy visits, where you're kind of celebrating still being in remission from this disease.
At what point do the patients come to you? Because I know there's a nurse navigator at Ascension Sacred Heart. So they find a lump and then they do what? They go to them first before you?
No. So people get into my clinic in all sorts of ways. So the most common way is that we have some great general practitioners and OBs in our community who are getting mammograms annually for their patients as is indicated, and they're picking up abnormal findings. Some of those providers decide to take the extra step and send them for a biopsy, and they actually end up in my clinic with, a cancer diagnosis. Other people say, there's something abnormal on this imaging, and they'll send them to my clinic, and then I'll be able to move forward with them and the radiologists in my practice with getting a biopsy. Other people, for whatever way, aren't connected well to the health system, felt something, ended up getting a biopsy, and then they're kind of plugged in either to me or to another surgeon through our nurse navigator.
And you're actually in the hospital? You're at Ascension inside?
I am at Ascension. My office is right behind the hospital. So I always tell my inpatients when they're asking where to find me that I literally walk back and forth. It's very easy.
Right. Well, yeah, Bay Medical takes up that whole section with the new building, everything, and everything is always kind of compact right across the parking lot. Like you said, you can just walk over. Let's talk a little bit about the guidelines. We have heard for years that women, as soon as you turn 40, get that first mammogram. You need that baseline, whether there's a history in your family or not. And we had talked a little bit before we came on live that I had seen some new guidelines, I think from the American Cancer Society, but it varied different agencies as to whether you could maybe wait till you're 44 if you wanted to. How do you feel about that?
I am a big believer in mammograms starting at age 40. I think the data is there for it. It's been well validated as a good screening test. We don't start earlier than 40, not because women in their 30s are not getting breast cancer. I think the youngest woman I've treated to date was 19 years old with a breast cancer. So there is a possibility for earlier cancers. But mammograms, they have a little bit of trouble in women who have extremely dense breasts. I'll sometimes tell my younger patients that come to me with indeterminate mammograms that it almost looks like a snowstorm, that it's hard between the really dense tissue to really pick up masses. Usually about at 40, women are a little less dense at that point in time, to the point that the mammogram can be read. The mammogram's a good screening test, and what makes a good screening test is that you want to pick up abnormalities that can be worked up with biopsy, but you don't want to be picking up a lot of false things, which lead women to having anxiety and getting unnecessary procedures and biopsies, and then it is really just nothing, that their study couldn't be read. So that's kind of how we've come to 40 as a point, because it's a time when the mammogram really becomes useful for women as a screening tool. For the average woman. Of course, density varies from person to person.
Right.
I'm a believer strongly from there in annual mammograms. We say breast cancer, but breast cancer, those of us that do breast cancer for a living, we see breast cancer as many different types with different degrees of aggression, with different degrees of tumor markers. For some women, they can form and progress to a pretty significant breast cancer within a year. So again, looking at risks and benefits of screening, nobody likes to get their mammogram. I've never had somebody come into my office and say, their mammogram is something they look forward to. I think it's kind of like going to the dentist, but
it's a necessary evil.
Exactly.
Yeah,
and
gotta have it.
The benefits of it, and then to continuing annually, just to make sure that you continue to stay in the window for things to be caught early. And then I think this is changing too, honestly. We used to the point of when to stop mammograms. Most of us that do cancer for a living kind of feel that not to stop them until life expectancy is about 10 years or less. Surgery and treatments have gotten very good and very safe. And I have operated on people well into their 90s for breast cancer. So I think that when we catch it early, it's such a favorable malignancy that we can cure people of in many cases. When we catch it late, it can really hurt quality of life. So I'm a huge proponent of screening, of catching early, and of getting those good outcomes.
Dr. Moody, great advice today. Do you have any one thing maybe that you hear from patients or you'd like to pass along as advice?
I think just so many patients I've talked to in my office who have been diagnosed at this point. I've already been fortunate enough to see many people diagnosed with new cancer since coming here in the last 2 months. And I think that there is a lot more fear around the diagnosis than there needs to be. like I said, the majority of patients, one of the things, let me rewind. One of the things I love about doing breast cancer, and one of the reasons I chose that cancer in particular, is because when we can get patients through treatment, the outcomes are excellent. And I know a lot of people who have seen, I think people even years ago, go through treatment with poor outcomes and are assuming that that's the way that it is today. And I'm sorry for people who have had loved ones that have had negative experiences, but I would say if you are concerned that you may have a mass, you may have nipple discharge, you may have something abnormal, come in and get checked. And if that comes back as a cancer, our treatments for breast cancer are excellent. I think surgery has come a long way, but I think chemotherapy honestly gets the most credit for coming the furthest. That our regimens are good, that we have some great medical oncologists in this county who can help women get through it, oftentimes without too significant a side effects. Just took care of a really inspiring woman who I asked she was doing on chemo, and she told me she was still going for a bike ride every day. So I think our reality that this is a death sentence, that chemo is going to kill you, those are some old ideas, which I'm hoping together we can kind of move past those.
That's good to know. There's more positivity.
Absolutely.
But you have to we're all afraid of the diagnosis, but you're right, early detection is key.
Early is good. And even for people that are detected later, our treatments still remain really impressive. A lot of people smarter than me have done a lot of research to really improve the treatments we have to offer and quality of life with that.
And we always talk about women because that's the majority of folks who get breast cancer. But we've had a couple of men, breast cancer survivors, who've come in to tell their stories. So we have to remind them as well, if you see something unusual, to check it.
Exactly. Yes. I've also treated a few men, and usually it gets bigger just for that reason, that men don't think they can be affected. But men can be affected. A lot of times when men are affected, there can be a genetic component there. So that's kind of a step should be as part of their treatment to look, could there be something genetic underlying that cancer?
Well, we certainly appreciate your expertise and your experience, and we're so happy you're in Bay County. We know we've had breast cancer surgeons in the past in the area who have retired, so there was a need there for this, and we appreciate that. Dr. Alison Moody, a breast cancer surgeon at Ascension Sacred Heart Bay. Good to have you in town. Thank you so much for coming out today.
Thank you very much.
Ladies, don't forget to check for lumps. Remind your husband to, if they see anything unusual, go to the doctor. Early detection, as Dr. Moody said, is key. Thank you for watching today. We'll see you next time.